We found that simple, what is current medication, immediately became a more complex problem, and one that is not fully solved. Do you want to know what is currently being dispensed? You can probably find that out. What do you do for a prescription that has been dispensed, has not reached the end date? I do not know if the patient is still taking that medication or if they threw it away. Is the statement as to whether the medication is active in the patient at this time? Some medications have a 6-hour body half-life. Some have a month and a half before the medication fully clears. Should I believe what the patient says they are taking? Sometimes I should not. So even the very simple, what is current medication, we had to start redefining that to say, we will present and capture what we know to be true and explain what it is that we mean by that, so that the physician or the pharmacist can make the right interpretation. So instead of saying current medication is this drug, we'll say this drug was dispensed to this patient on this date with these instructions. That we know. We hope the patient is following the instructions and taking the medication, but that in an outpatient, we do not know. In an inpatient environment where the nurse is administering the medication, you will know that the drug had been administered, and you'll report current as this drug was administered because you know it was administered by the nurse. And it dug into what is relevant, what is active, and there's ongoing series of what can we actually determine, capture that in the medication record so that the people using the record can make the right decision on how to interpret that information. This has, computer? What do you mean? Thank you. This has posed some issues. Data may not be available. Data will be incomplete. Data is not in all one place. Different countries handle community pharmacy different from in-house pharmacy. Patients travel across borders. Patients share their data. Immunization is considered a medication in some countries. Immunization is not a medication in other countries. Oncology drugs are a medication, but they might only be in the oncology system, especially radiotherapeuticals like radioiodine. So as you get into radiation oncology, I have to talk to the oncology machines to deal with the nuclear medicine issues and the radiotherapy issues, which may not be anywhere in a pharmacy system. Again, it depends on different countries. We then had to pin down, what does it mean to be ordered or prescribed? These are administrative definitions in different countries. So again, a lot is being done in terms of document it and document what the word means. And sometimes people will be disturbed that in their country, when they ask about a prescription, they will get one kind of information. When they get the records from another organization in another country, they cannot find that. They will get a related piece of information. I have seen in some countries dispensing is by the bottle. In other countries, dispensing is reported on the first bottle. So if I have a renewable prescription, I might not know about when each of the renewable bottles was handed to the patient. And of course that matters. And then there's drug proprietary names. And indeed, I suspect this is one of the areas where I've seen every nation have many different rules. Do you use the proprietary name? Do you use the name of the active ingredient? Do you worry about the formulation? Do you worry about the passive ingredients, the buffers, packaging? Is it a tablet? Is it a powder? And again, what we've taken is the approach we will capture what we know, record what we know, and it may or may not match what the pharmacist needs, but it at least is what we know. Now, the other area that we have not tackled yet is the medication lists. The issue of formulary. What are the current approved drugs? What are the recommended drugs? What is the present advice? This has been separated out. At the moment, it's very much what have we observed? What do we know has happened? What do we know the patient has done? That we can capture, that we can be accurate. It becomes very much, you get hospital policy, regional policy, national policy around recommended drug formulations. At the moment, we're letting those be separate. Another thing that we are thinking about, again, and this one we're getting closer to, is traceability, especially a problem with counterfeit drugs. As soon as you have discovered an issue with counterfeit drugs, you need the traceability interface to track down all the other patients that have been affected by counterfeit drugs. I'm not sure how big of an issue it is here, but it's become a very significant issue in some countries that you discover counterfeit drugs that are not effective and you need to get them out of the system and recognize that fact with the patient treatment. It also becomes an issue for some drugs that expire rapidly. Doxycycline becomes toxic after a couple years. You need to get your doxycycline out of the system before it becomes toxic. And with all the radiopharmaceuticals, you have to track half-life. You have to track where it was made. Those are in the immediate future of work. So our approach has been now to support the decision about what medication has been made by presenting the best available information together with a statement of what that information is based on. It often will not be what you would prefer the information to be based on, particularly an outpatient. The patient doesn't tell you a lot, you don't know a lot. All of the problems I've seen have been patients who do not follow instructions. They follow what they think they ought to do, perhaps what their neighbor told them, or perhaps what they remember from 15 years ago, and they completely ignore what the physician told them to do. And there's no way that we can capture that fact here. We've made a domain model so that the data can be kept constant. We capture it from the scientific measurement perspective rather than from the procedural perspective, so that each country, as it changes its procedures, can take its own approach. It can use the same scientific measurement information so that we say, dispensation means this, administration means this, and you're free to interpret. We are avoiding terms like treatment start date. It sounds very good, but does treatment start when the patient swallows the pill, or when the prescription is made, or when the doctor tells them what to do. We discovered that some terms like treatment start that you find in HL7 are highly ambiguous when you try to apply them to medication. Treatment start is simpler for things like surgery. You do know when a surgery starts and stops. With medication, it's much harder. You don't really know when the patient starts taking the medication or when they stop. And we will be having to adjust this as our understanding expands. We have work that is in trial implementation to gain experience, but expect that these will change as we learn. We learned a lot from the simple, we have a doctor who makes a prescription, the pharmacist needs to review the prescription and then administer it or dispense it to the patient. That sounded simple. That is not simple. Now, we are just now tackling ingredients. I am not an expert in ingredients, other than to have discovered that there are probably 20 different names by 20 different organizations for each pill, tablet, or liquid that people administer, and that this will be a big problem because they have not agreed on how to name a drug. They have not agreed on how to name active ingredients. They have not agreed. And we have to use the information provided by the drug maker. So instead, we're defining a pool of what we do know. We will validate and implement that pool of data terms and extend it. And the way we're doing that is through profiles where we will learn. We'll start with the simple, expand the pool, implement the profile, learn from its use, revise the profiles, extend the data set, and it's started to work. So at present, we have some profiles addressing these aspects of the workflow. Prescription systems, which are all of the different sources. It's usually a doctor, but there are other sources of prescriptions. How do they document what they have prescribed? That documentation will be sent to both dispensing systems and administration systems. Dispensing systems worry about pharmacy approval. There's a worry about negotiating alternatives when there's stock issues. There's worries about alternate approvals, board approvals, insurance approvals. Those are in the dispensing systems. And administrative systems, worried about inventory control, expiration dates, order requirements, shipping requirements. There's quite a lot of players interested in how to do this, what's been ordered so that they can ship to keep inventory in stock and avoid delays. All of that is going to a data collection. I'm not sure all the things that will be done in the data collection area, but a lot of the medical oversight, review boards, administrative boards need to track on a population basis what is happening with drugs. And finally, the patient who needs medication information increasingly wants that electronically. They don't want just the pill bottle, they want at least a reference link, documentation. There's lots of advice on using it on the internet. If it's complex, like injections, they want some way to know where are the videos, where are the instructions. And that's coming. The definitions right now are still a work in process. I've described the problem. We have drafts. The agreed needs are there, and we have 5 profiles that are being tried that test the definitions people can use. I'm sure we welcome participation, feedback on how these trials need to be changed, how they need to be augmented. But these 5 documents are available. The community medication is aimed at outpatient ambulatory patients in a community environment. So it's not dealing with cross-border, it's dealing with their home environment and dealing with receiving, tracking prescriptions and receiving and tracking dispensing of those prescriptions so that the doctors who are treating them will know at least when they picked up the medication from the pharmacy. They will not know whether the patient took the medication, but they will know it has been picked up. The hospital medication workflow is very much for when the medication is delivered and administered by a nurse or orderly or hospital staff. Now you have different information. Now you do know when the drug was genuinely administered, not just when it was dispensed. So there's additional information in that workflow. Pharmacy dispense is tracking all the dispenses so that outside of any workflow you can say what was dispensed to this patient. Advice is there so that a pharmacy review can take the pharmacy, the prescription, review the available medical information, and provide advice on whether or not this is appropriate. Some drugs, some areas, pharmacy advice is mandatory before you dispense a drug. Others, it's optional. It depends on the drug and the location and the dangers. And then finally, a generic prescription mechanism of this is how we document a prescription. Without a workflow, it's just this is how a prescription is documented so that any workflow that is concerned with documents, with prescriptions, knows how a prescription is documented. And in this case, prescription means the prescribing clinician, the physician, has officially said this is the prescription that should happen. It does not mean that it has happened or that pharmacy has approved it or anything else. Now the immediate next steps, and here this is more IHE internal speak, is to make use, for those who have looked in it a bit more detail, there is a notion in IHE in the database world about on-demand documents, which are a mechanism for creating new documents upon request so that you can ask, I need the current list of prescriptions. And we are expecting to use that facility and define it so that these dynamic documents can be created for pharmacy events. I have forgotten what RECON stands for, but it is a technology being looked at for tracking and managing the pharmaceutical activity. And there's still more definition work to be done. We are continually getting feedback about more definition that needs to be done on terminology. At the moment, I think it's going to be like oncology, that there is going to be pieces, slice after slice, of terminology development for pharmacy. That there is no single, here are all the pharmaceuticals. And I believe, whoops, yes. And
okay.
Questions?
Thank you very much.